Welcome, and thank you for joining the Health Effects Institute 2020 webinar series. I'm Pallavi Pant, a staff scientist at HEI, and this session was co-organized by Anna Rosovsky, also a staff scientist here. Along with the rest of staff at HEI, we hope that all of you are safe and healthy during this very challenging time. As you know, we are holding 5 webinars in lieu of the HEI annual conference that was planned in Boston in early April, but had to be canceled due to the coronavirus pandemic. Today is the 5th and final webinar in the series. The topic of today's webinar is Inequalities of Air Pollution Exposures and Associated Health Effects in the US. We are very grateful that the session organizers and speakers and chairs have agreed to give webinars and really appreciate all of you who've been joining us from around the world. We also want to thank the HEI staff who've been working very hard behind the scenes to transform the annual conference into a webinar series. Before we jump into the webinar, we'd like to let you know that HEI is currently soliciting applications for research on air pollution, COVID-19, and health. All details are available on our website, and we encourage you to apply. Today's session is going to be chaired by 2 members of HEI's review committee, Dr. Jana Milford, who's a professor in the Department of Mechanical and Environmental Engineering at the University of Colorado Boulder, and Dr. Michael Jarrett, who's a professor and chair for the Department of Environmental Health Sciences, Fielding School of Public Health at UCLA. Before we begin the webinar, I'd like to quickly go over some housekeeping announcements. All of you are going to be in view-only mode throughout the webinar, but can submit question and answers for the Q&A period at the end. You can use the QA function at any time during the webinar, and you can also upvote questions that have been added by other people. If you have any logistical questions or difficulties, please let us know via the chat function or send us an email at jkeel@healtheffects.org. This session and all other sessions have been recorded and will be available on YouTube in the next few weeks, and links will be available on our website. Finally, as we close this webinar series, we really look forward to your responses on how the series went and any future webinars you would like us to organize. Today's webinar focuses on the inequalities and exposure to air pollution in the US, and we're going to hear from a very exciting lineup of speakers on our current understanding of this topic, as well as key questions for research and policy applications. With this, I would like to hand it over to Dr. Jarrett for introductory remarks and to introduce our first speaker.
Thank you, Pallavi. It's my pleasure to be here to share some thoughts on environmental inequalities. I'm just going to share my screen. Can you see it now?
No, we cannot see it.
No.
Oh.
Okay. There we go. You have it now?
Yes.
I'd like to just give you a very high-level overview of what I see are some of the key issues when we look at environmental inequalities. And I want to address a couple of questions. Why would we care about them, and what can we do about them? First point is that when we look through time, socially disadvantaged groups, however they're defined in a particular society, are exposed to higher levels of environmental stressors like air pollution and lower levels of hallucinogenic exposures like parks. And this is incredibly consistent over time, space, and many different places. Whether we look at the squalor of industrial revolution, England in the 19th century, where there was high rates of infectious disease like cholera, very high levels of indoor and outdoor air pollution from coal burning, and overcrowding, or 20th century industrial complexes in my former city of Hamilton, Canada, a large steel mill. Interestingly, this street is called Cope Street, and you can see that the population is probably coping with more than air pollution. They have poor quality housing. They have a lot of domestic violence in this area. So there's an accumulation of effects to 21st century logistics facility and just-in-time shipping. This is the 710 freeway coming out of the ports of Long Beach and Los Angeles, with about 40,000 containers a day being offloaded onto trucks and going through disadvantaged communities of color like Wilmington. This is my very first paper I ever published way back in 1997. I hate to date myself like that, but it was viewed with, I think, curiosity in Canada, because no one had ever thought that, you know, kinder and gentler Canadians would ever have environmental inequalities because they had universal health care and a fairly advanced social welfare system. But in fact, we did discover very persistent inequalities in Canada. And even when I worked with my colleague Basil Shea from France and his colleagues from Sweden, we found that in what is arguably the most egalitarian advanced social welfare state in the world, Sweden, we still found very high levels of inequality. And this is showing school children at their residence and at their school. And you can see the nitrogen dioxide goes up as the income goes down. So environmental inequalities have this incredible consistency across places, even in Sweden. And now we're seeing numerous examples of how globalization exacerbates international inequalities. And this interesting article from China shows that about 200,000 deaths in China are related to the production of goods that are shipped for export, mostly to the United States. So here we have an example where the spatial scale is expanding, but the story remains the same. Now, when we look at possible explanations, one that resonates with me is Lincoln Felon's fundamental social causes, that the disadvantaged will continue to bear higher risks because those who have more education and more resources will always find a way to protect themselves more than those that are less advantaged. But as Mackenbach has pointed out, there, in his extensive study of 19 European countries, while this fundamental social causes is alive and well across Europe, there are differences between countries. So there's certainly more to it than that. So returning to these questions, if the process is so persistent over time, space, and place, why should we care? Perhaps it's unavoidable. But I think when we look at health inequalities, and we know that many environmental contaminants are likely to cause illness and death, that some of these health inequalities are almost certainly linked to these environmental inequalities. And what can we do about it? Dr. Levy's going to talk about how we can supply systematic information on single and cumulative exposures, and we can make it a fundamental right and ensure that policies take that into account. And Dr. Eady is going to cover that when she looks at the revolutionary new bill in Canada, Assembly Bill 6, or not in Canada, in California, Assembly Bill 617. This is a very brief chart showing what I call the double jeopardy hypothesis. It was coined in 1999 by the Institute of Medicine in a seminal report. But the basic idea is that we do have disparities in exposure, and these are cumulative and multiple, ranging from traffic pollution to hazardous occupations, higher levels of indoor air pollution. But that the groups that are experiencing these higher exposures are also probably more susceptible to the effects of those exposures because of poverty, malnutrition, higher psychosocial stress, and underlying disease conditions, to name a few. And this is what contributes to the environmental health disparities. Now, if we look at exposure to green space, which one of the hypotheses there is good for you because it moderates the effects of air pollution exposures, you can see here in this seminal study by Mitchell and Poppin that where we have little green, the darker bars are showing us the lowest income and the highest income are in the lighter blue. The gradient between the highest to lowest is much greater than it is in the very green places. So this is just one tangible example of how the salutogenic exposure could moderate air pollution effects. Or if we were to reverse this, we would probably see the opposite and increasing health disparities as pollution went up. And I want to point out that this is not just something for the past, and it's not something that is going to go away, but it's something that is having very continued implications for some of the biggest risks we now face from climate change. And this is a very interesting paper just published on environmental justice and transitioning to a low carbon future without disadvantaging those communities that are already experiencing numerous other risks. So I'd like to end it there and turn to Professor Sam Harper, who's going to talk about social determinants of health and give us some of the concepts and methods. Dr. Harper is an associate professor in the Department of Epidemiology, Biostatistics, and Occupational Health at McGill University. He focuses on understanding population health distributions and their social implications, and how the distributions are varied by different levels of social status. And he has particular interest in evidence construction, measuring health inequalities, global health, demography, causal inference, and finally, ethics in public health. So I'll turn this over to you now, Dr. Harper.
Thank you very much.
And I've stopped sharing, so you can begin.
Perfect.
Thank you.
Thanks very much for inviting me. It's a real, excuse me, pleasure to be here. I'm really happy to be part of this webinar. So the recent coronavirus pandemic has, I think, strikingly demonstrated the way in which underlying social conditions interact with the environment to produce differential health outcomes was recently illustrated in this report from the New York Times. Although I really wanted to refrain from talking about the coronavirus pandemic, I mean, I think as it turns out, it provides a really useful current example of how the social determinants of health help to enrich our understanding of environmental exposures. Louisiana was the first state to release COVID-19 death data by race, with rather, I think, astounding numbers of excess deaths among Blacks. And that's turned out to be evident for many other states as well. These disproportionate impacts highlight the way in which underlying inequalities can exacerbate the impact of novel or common exposures. In particular, Beverly Wright, the executive director of the Deep South Center for Environmental Justice, that explanations for racial inequalities in COVID-19 deaths have not seriously reckoned with the long-standing systematic harm done to communities of color by air pollution, which of course may exacerbate exposure to coronavirus and is a consequence of decades of structural inequalities. Interestingly, and somewhat fortuitously, I think for me, the New York Times piece concluded with a choice quote to help introduce this topic. They noted that the conditions in the social and physical environment where people live, work, attend school, play, and pray have an outsized influence on health outcomes. Those in the public health field call these conditions social determinants of health. So my job today is to really sort of set the stage for a discussion about the role of social determinants of health in the context of air pollution. As a preview, I would say sort of the main message I want to get across is that health outcomes are produced through a complex set of social relations that allocate risks and benefits to different social groups. As is evident from the current pandemic, failing to consider social determinants of air pollution, I think, will lead to degraded inference and to less optimal policymaking. Incorporating social determinants into air pollution research, I think, will produce better science, and that's the main message from today. So where did this idea come from? What are social determinants of health? In the next few minutes, I'll give a brief history of the social determinants of health and how they may relate to air pollution exposure, with some implications of this approach for studying the impacts of air pollution. So as was noted in the New York Times piece above, the social determinants of health are the conditions in which people are born, grow, live, work, and age. This definition comes from the World Health Organization. But often you'll see long lists of determinants, like this one from the Centers for Disease Control and Prevention, highlighting factors such as socioeconomic conditions, residential segregation, community resources. These lists are often long, but they typically do not include things like using medical care or behavioral risk factors like smoking. So the notion of considering social determinants of health goes back quite a long way, but to put, I think, some of the recent academic emphasis into context for today, I think it's worth a short history of how we arrived at this present definition of social determinants of health. So what are some of the core concepts in the social determinants of health approach? So in many respects, the modern notion of social determinants of health can be traced to early studies in medical sociology in the 1950s, And of course, the idea goes back much further than that. But as infectious disease mortality declined and the epidemic of cardiovascular disease emerged, the notion of multiple causes of disease took hold, as well as, I think, an attempt to understand the causes of declines in infectious disease mortality. And so historical work from people like Thomas McEwen, John McKinley, and others showed essentially that very little of the decline in infectious disease and across multiple infectious diseases was due to medical innovations. Rather, the main drivers of the downward trajectory of mortality were economic conditions, improved standards of living, and social policies. And whereas the work of McEwen, McKinley, and others really helped to show that medical care played little role in determining average health outcomes, so population health outcomes, the Black Report on Health Inequalities in the UK in 1981, I think really helped to cement the notion that medical care alone also unlikely to reduce social inequalities in health. It was widely hoped that the introduction of the British National Health Service in 1948 would usher in faster health improvements among the poor. But the Black Report found very little evidence that this was the case. And I think this really helped to refute the idea that health inequalities were due to a lack of medical care and helped to make the case that more ambitious interventions in housing, education, and other social determinants were needed to reduce health inequalities. And the idea of persistent health inequalities over time has also helped to frame arguments that what really mattered was not the precise mechanisms that generated disease, but rather fundamental social conditions, which Michael already alluded to. Lincoln Phelan, among other people, have argued that social inequality produced inequalities in cholera and diarrheal disease in the 19th century via dirty water and unsanitary conditions, just as 150 years later, social inequality is producing inequalities in heart disease and lung cancer in the 21st century via behavioral risk factors like smoking and diet. And so in many ways, I think the persistence of social inequalities in health by income, by ethnicity, race, geography, despite massive changes over time in the disease environment, led many to suggest that explanations for the patterning of disease needed to incorporate social factors, and that the way to reduce health inequalities was to intervene upon social stratification itself. And I think this work was buttressed by an explosion of research in the 1970s and 1980s, identifying new and novel individual risk factors, especially for chronic diseases like heart disease. So the discovery of these risk factors naturally led to questions about whether relative health inequalities could be explained by these risk factors. And I would say much of the literature concluded that the answer to this question was no, either for social class inequalities or for race ethnic inequalities. Jeffrey Rose and Michael Marmot, after analyzing their study of British civil servants, concluded that there were likely to be unidentified risk factors out there that had not been seriously investigated. So the fact that relative health inequalities could not be explained by traditional risk factors spurred a good deal of interest in exploring new or perhaps rediscovered avenues of explanation. I think two key directions that came out of this were an interest in multi-level analyses exploring kind of the simultaneous effects of larger social and physical environments, such as neighborhood and community level exposures, as well as research into psychosocial factors, stress, and health. And I think another key idea for the social determinants of health movement, really, which is wonderfully illustrated in Jeffrey Rose's small book, The Strategy of Preventive Medicine, was that if the primary drivers of population health were economic and social factors, then interventions to change population health should also be economic and social. So trying to explain differences in the distribution of, for example, cholesterol between Japan and Eastern Finland through just looking at individual level risk factors misses the larger drivers of the entire distribution across these two environments. And this is true not just for chronic diseases. There's a more general point about the difference between what we might call sick individuals versus populations. So to use a different example, being a young man increased the likelihood of perpetrating a homicide in both England and Chicago. That does not explain the fact that Chicago's homicide rate was roughly 30 times higher than England's in the 1990s. I mean, that gap has to do with underlying differences in social conditions in the two areas, and of course, a huge number of guns in Chicago. So by the early 2000s, there was a sustained interest in social determinants of health, I would say across most rich countries, and the notion of expanding that frame to consider the really, truly staggering health inequalities on a global scale led to a large investment by the World Health Organization to launch a commission on social determinants of health in 2005, and this resulted in a highly publicized report in 2008. And there are many criticisms that can be leveled at this report, but I think it did really help to put social determinants on the international agenda for essentially all countries. So the last thing I'll say in this sort of historical framework is just to talk about this model of social determinants. At its core, the social determinants of health model treats the underlying social structure as a dynamic base that allocates resources that, through the process of social stratification, lead to differential social positions, so income inequalities, differences in education, and the like. These in turn affect whether and to what extent different social groups may be exposed to health damaging factors like particulate matter or to health enhancing resources like green space, as well as how different social groups may be differentially affected by these kinds of exposures. And finally, access to resources, I think also affects the consequences of getting sick and the impacts of different kinds of treatments, which then, of course, can contribute to further stratification in the next generation. And so I think this entire chain helps to provide both explanations for observed inequalities in health as well as their persistence over time. However, I think it also exposes key points of leverage for policies and interventions to reduce health inequalities. So at each node of social position, exposure, vulnerability, and consequences are opportunities to intervene to disrupt the reproduction of social inequalities in health over the life course. And that these interventions are upon social factors rather than additional risk factors, I think is really sort of the essence of the social determinants approach. And of course, I think these ideas are relevant to air pollution research. There's a long history of the environmental justice movement that is focused on explaining and actively opposing the unfair social distribution of environmental hazards. And of course, there's a solid history of research on environmental inequality, as well as good evidence for the persistence of spatial and social inequalities in exposure to environmental contaminants and exposure over time. So these studies, of course, raise the same kinds of policy concerns about the inattention to underlying social determinants of differential environmental exposures. And similar to Jeffrey Rose's study of cholesterol distributions in Finland and Japan, or the comparison of homicide rates in Chicago versus England, it's not hard to suggest that the distribution of environmental hazards across countries or across communities within a country reflects primarily social and economic processes that shift entire distributions of risk higher or lower, rather than individual level choices. And of course, there's already a lot of research on social determinants within environmental epidemiology. Recent systematic reviews of studies of the intersection of air pollution and markers of social position demonstrate important heterogeneity across studies. So this may partially result from differences in the units of analysis, different study designs, different use of different statistical methods, or perhaps genuine differences in the effects of exposures across different contexts. Nevertheless, I think these reviews generally also find that the balance of evidence suggests that environmental risks are more concentrated among disadvantaged individuals and communities. And these reviews, I think, also have suggested greater attention to methodological details, which I think is also valuable and needed. So this brings up a few methodological issues worth discussing before I finish up, many of which I think will be covered in greater detail by John, Jane, and Veronica later, but a couple of things stand out. I think one is to be clear about what the goal is of any study that is seeking to try and incorporate social determinants and environmental exposures. So is the point just to describe differences in populations or to measure environmental inequality? These purely, I would say, descriptive studies need to pay really close attention to the units of analysis, the measures of inequality. John will talk about this shortly, and to the measures of social position that are used to make inferences about inequalities, because these things can have really important consequences for study results. And I want to just say briefly, right, there's no single best measure of socioeconomic position. So by definition, it's a latent construct. So at the individual level, for children, for example, we may use their parents' income or their parents' education as a proxy for their social position. But for young adults, it may be their own education that really matters. And individual measures of social position in adulthood really also, of course, depend on their prior personal exposure to different kinds of histories over their life course, as well as differences in what may determine the relevant risk for a particular environmental pollutant, right? So the relevant social exposure for asthma may not be the same as for PM 2.5. So similar questions arise for measuring the social position at the community level. These questions are just unavoidable. Moreover, I think one thing I'd like to stress is that for any given measure of social position, right, social position is not a static quantity. So this example shows changes over time in salaries for teachers and non-teachers in the United States and how they've diverged over time. So using occupation either as a confounder or as a moderator may have a very different meaning in 1970 versus 2020, or across countries with vastly different occupational hierarchies, since a given occupation can provide really different resources depending on the overarching social structure. So similar arguments to this could be made for measures like education, since we know that the wage premium on something like a high school or a college degree can change drastically over time. So that's on the descriptive side. I would say, the other side about clarity in terms of study goals is rather than describing differences, other studies may want to say something about the potential for interventions, either on environmental exposures or on social exposures or both. So these studies not only need everything we talked about in terms of good measurement, they also need credible study designs to make causal inferences. And this isn't easy, for either social determinants or for environmental exposures. Much of the evidence of the WHO Commission report I mentioned earlier on social determinants, I think, can be questioned on methodological grounds. I certainly have questioned some of it. But these exposures are hard, if not impossible, to randomize. So we have to take a lot of care in being clear about how we decide to make inferences to justify interventions. And that's the hard work of causal inference. So as one example I'm showing here, these are two different causal models that provide important implications for what kinds of adjustments may need to be made in a statistical model to estimate causal effects. So these models are super useful. They can also help to guide analyses about the extent to which socioeconomic factors may confound estimates of air pollution as an exposure. I would say these things are really valuable for formalizing relationships between exposures. But of course, the devil's in the details, and there can be, reasonable or perhaps maybe unreasonable disagreements about how realistic or evidence-based these kinds of models are. Yet I do think that they are really crucial for trying to make reliable causal inference, which is needed for any realistic discussion about interventions to reduce health inequalities. I'd say the last methodological point, which is, I think, kind of self-evident, but I would say by definition, studying human beings means understanding multiple causal chains operating at multiple levels. So social and economic factors that constrain housing opportunities, for example, can't simply be studied focusing only on individuals. There's a rather, persistent need to integrate factors operating at multiple levels in these kinds of analyses. And this means that researchers need to grapple with these questions and perhaps embrace different methods than traditional, for example, cohort studies. So I'll use one last example to highlight this, which was a recent study utilizing econometric decomposition techniques that aim to unpack how many different risks, including both neighborhood, environmental, and individual risks, may work together to explain social inequalities in health. So a key message from this was that the contribution of PM 2.5 to explaining racial differences in preterm birth was comparable to other traditional risk factors. And of course, there are important methodological concerns that need to be addressed in these kinds of studies, as in all studies, but I think this could be, again, a promising approach that is perhaps been underutilized to help understand how differential environmental exposures may play a role in generating health inequalities. So to finish, I would say, paying lip service to the social determinants of health is pretty easy. They're vague. They're often not expressed with a lot of certainty. I think the really hard part is doing the work to understand how specific social factors are implicated in chains of risk, exposure, and disease causation. So in order to formulate sensible interventions and to avoid unintended consequences, we need to do the hard work of causal inference, I would say broadly speaking, to create a solid evidence base for action. So taken together, I do think that incorporating social determinants of health into environmental epidemiology will make for a richer and deeper explanation for the distribution of risks and for how we can remediate them to reduce social inequalities in health. Thank you very much.
Thank you, Dr. Harper, for that very insightful and interesting overview of the social determinants and their links to air pollution. I'm going to turn it over now to my co-chair, Dr. Milford, to introduce our next speaker.
Thank you. The next presentation addresses the issue of quantifying air pollution exposure inequality. And our speaker is Dr. Joan Levy, who is professor and chair of the Environmental Health Department at the Boston University School of Public Health. His research focuses on urban environmental exposure and health risk modeling, with an emphasis on spatiotemporal exposure patterns and related environmental justice issues. He co-directs the Center for Research on Environmental and Social Stressors in Housing across the life course and has been a member of several National Research Council committees, including the Committee on Science for EPA's Future. I'll turn it over to John.
All right, thank you very much. And yes, thank you to everyone for having me here today. Hopefully you can see my screen fine. So what I want to do is really talk a bit about maybe a follow-on to what Sam was presenting, how we think about quantifying exposure inequality for air pollution in particular. And I'll explain a little bit the rationale and the approach in a few moments. But like Sam, I think it was hard to even start to think about this topic without getting to the present moment and thinking about COVID-19. Clearly we're in a moment where we're thinking quite a bit about social inequities and inequities in health outcomes. These three headlines are from recent popular press articles that talk about, for example, connections between environmental justice, communities, and disproportionate burdens from COVID-19. The top is from the Massachusetts Attorney General, who put out a report about 2 weeks ago. Similar things happening in New York and elsewhere, where we're not just seeing the initial discussion about disproportionate health burdens of COVID-19 or even about possible effects of air pollution, starting to get into these conversations about environmental justice. So I think this is front and center at the moment. But I'm going to leave right there the context of COVID and spend the rest of the time thinking a little bit about the history as well as the more current use of these types of indicators. So if we go back in time to the early days of the Clinton administration, there are actually two different executive orders that I think have a lot of bearing on the policy setting and the context in which you might want to use an inequality indicator. So the first one listed here is the executive order that called essentially for benefit cost analyses of regulations exceeding a certain dollar amount. And what I have highlighted here in red is the fact that although these regulatory analyses that were launched by this really focus on comparing health benefits to cost of regulation, this is not strictly a tallying of things on both sides of the ledger. Distributive impacts and equity are meant to be considered. The second executive order that followed shortly thereafter in the Clinton administration was about environmental justice and trying to bring environmental justice into all environmental policies. And what I've highlighted in red here is that although oftentimes we think about this executive order and environmental justice on a procedural side of making sure different groups of equal participation, equal access into citing decisions, for example, the executive order calls for a look at disproportionate health burdens as well. And so if you couple those two, which again came within a year of one another, you get a sense that for large regulations, we need to be thinking about how the health benefits are distributed and really understanding if there is a disproportionate burden on minority and low-income populations. So the door is open to do these types of analyses. Unfortunately, this has not really been met by formal analyses and formal methods. And so this is taken here from the regulatory impact analysis for the Clean Power Plan rule from the late Obama administration. I'm not picking on this analysis. The same story could hold for pretty much any regulatory analysis over the past couple of decades. So in a 343-page, very detailed analysis, neatly tucked in somewhere around page 329 is the obligatory section to look at environmental justice. And it indeed feels obligatory. It only takes up about a page, and it has phrases like the quotes below which essentially say, we thought about the fact that there are vulnerable populations in this case, and if we're going to be reducing exposure to air pollution, it will be reduced for low-income populations too, and that has to be good. And so it doesn't give you a lot of confidence that environmental justice is actually being used as a decision criterion versus just a box that has to be checked. And so the real question then becomes, how could you make it more formal? How could you actually use it as a way to distinguish among candidate policies and think about how it best addresses environmental justice? So just as another quick example that's more contemporary, the Transportation and Climate Initiative is an ongoing policy discussion / collaboration among many states in the Northeast. The goal is to reduce carbon emissions from the transportation sector to address climate change. And the policy model is similar to a lot of other prior policies, a cap and invest model, again, sort of analogous to cap and trade models, where then, frontline environmental justice communities become concerned about whether these kind of trading schemes or these cap schemes would actually lead to health benefits for these defined populations, or in particular might help to remedy historic discrepancies. And so there's value in having an analytic approach where you could look at patterns of air pollution reduction across different policy options and be able to say, oh, this one has a better shot of addressing environmental inequities or environmental justice issues. So now moving on to the methods, that you can quickly see how this can become quite challenging. And I want to spend just a minute talking about terminology, which matters quite a bit here. So if we're talking about quantifying things, there are quickly a number of things you simply cannot quantify. And so this is from a paper that Sam Harper and I, among others, co-authored that made it clear that inequality, which is just a measure of differences between groups or differences in the distribution between groups, it's a quantitative measure. It can be readily characterized, readily quantified. When you get to inequity, this takes the inequalities and tries to judge, is this fair or unfair? So there's some societal calculus that's placed upon that, right? If I get 10 pieces of candy, you get 5 pieces of candy, that is unequal, but we may not consider it inequitable because we may not be concerned about who gets the candy, or there may be reasons for it, or maybe something easily remedied. Unfairness, again, requires this social calculus, and injustice, another layer related to process. So we can assign numbers and calculate inequality. We can't calculate inequity. But that said, we can be given roadmaps by policymakers on what kind of differences are considered unfair. And again, go back to the Clinton executive order on environmental justice. It specifically described the types of populations that were of concern from an environmental justice perspective. So we have a mandate in an executive order that says, worry about differences for these populations in these ways. And so that allows you to interpret an inequality measure as a potential measure of inequity. So then the question is, how can you do it? I put how in parentheses because there's a question of, can you quantify exposure risk inequality, and then therefore how can you do it? Now, this has been done for a long, long time in economics. For measures of income inequality, date back to, I think, the 1920s, perhaps a bit earlier. So it's been a century plus where we've taken quantitative measures to assemble distributional data for income and put it into a single number so we can track trends in income inequality over time. So the question really becomes, can you use these metrics or analogous metrics for air pollution exposure or health risk, or can you use perhaps derivations of those metrics? And so there's been a lot of back and forth in the literature on this. Health inequality has been quantified using these metrics for many decades. I put here a quote from one commentary that tried to argue that you couldn't do this for health inequality. And I put it up and have two of his core arguments because I think it's worth putting forward. The first of the arguments was essentially these income inequality indicators were made for goods, right? Having more money is better than less. Risk is a bad, right? Having more risk is worse than having less. And so direct application of an indicator built for a good to a bad is not necessarily interpretable. And this was a fair point, though you can imagine there are statistical transformations that one could do to counter that, and that's what's often done in the literature. Another key point that's maybe a more subtle one is about transferability, basically saying if I have a lot of money and you have less money, that can be remedied by me transferring some of my income to yours or having taxes that do so. For health risk, I cannot literally transfer my risk to you, or if I have more air pollution exposure, I cannot give it to you. So there's, the argument goes, an inherent limitation or inability to conceptualize these indicators in the same way for risk. I think a very important counter argument here, though, is that exposure is actually transferable at a policy level. I can't give you my exposure, but if we're considering competing policy options, we can have one policy where my exposure is reduced, another one where your exposure is reduced, and we can compare and contrast those policies. So there actually is ability to change the distribution of exposures through different policy and intervention measures, and therefore to transfer exposure and health risk, again, at a policy scale, if not at an individual scale. So then that gets into how you do this measurement, what some of the inequality measures are. This is a long table from the paper that Sam and I and others put together. I'm not going to go through all of this, have no fear. This is in part just to simply show that there are many indicators that can be used, many statistical constructs, and they have perhaps differing interpretations beyond just their differing equations. So, for example, you can look at people in comparison to the average person or the best off person as your reference group in determining inequality. You can be concerned about absolute or relative inequality, meaning are you looking at the ratios among people and how those are changing, or the differences among people. You can have ways to have your aversion toward inequality actually formally parameterized, or it can be baked into the equation. And you have measures that are intended strictly for ordered social groups, meaning income, where there's an obvious gradation from low to high, versus, for example, if you want to look at race, ethnicity, where there's not an inherent ordering of those groups. And so, of course, for any of these things, there's not a right or wrong answer. It's not that there's a combination of these that is correct and others are incorrect. It's different ways that decision makers and stakeholders can look at inequality and interpret it. And so for the purpose of the presentation today, I'm just going to talk about the Atkinson Index. That doesn't mean it's the best or the right one. It's one that's been most commonly used in the air pollution literature, and it has some desirable features that I think merits its discussion. I'm not going to get into the details of the equation itself, but suffice it to say it fulfills all the basic axioms. These indicators were generally constructed to fulfill a certain set of standard axioms to be applicable, and it works. It is also something called subgroup decomposable, which essentially says you can take the total amount of inequality that's out there. Again, it's say air pollution exposure has a certain amount of inequality, and you can divide it up into between group versus within group differences. So of the total amount of exposure inequality, how much is related to differences between racial ethnic groups versus just geographic patterns and within group differences. And you can see how this could be quite important when we're thinking about environmental justice and defined populations. We're not simply interested in, are there differences in concentrations? We want to know if there are between group differences. And I mentioned previously that having an explicit inequality aversion parameter, that's what this epsilon entails. So as an analyst, you're not baking in the notion of how worried we should be about different types of inequality or inequality in different parts of the distribution. You can look at the sensitivity to a range of values of epsilon. Now, something else that we did a number of years ago when we were first thinking about applying these indicators in the realm of health risks was to put a few other rules in place about how you might want to use these quantitative indicators in a health risk context. And these are just a few from this 2006 paper we did. One, which, seeing it on the slide, it feels fairly self-evident. If you're worried about health risk, you should use health risk, or you should look at something as close to health risk as possible. And while this seems quite non-controversial, I think it's probably especially in this audience, a lot of the literature at that point didn't do this. Most of the analyses focused on proximity to polluting facilities, in part perhaps as a surrogate for exposure, perhaps as a surrogate for just political engagement and the ability of certain communities to affect facility siting. But regardless, there wasn't a lot of explicit look at exposure or risk. And so we wanted to articulate that if that was the end goal, ideally you look at risk. If you can't do that, look at exposure. If you can't do exposure, use concentration and so on down. It's also important to look at the baseline distribution. So we're not just interested in if you intervene, who is receiving the benefits. You want to know if you are remedying existing inequities and what those look like. And these indicators really have the most value if you're comparing multiple policy alternatives. So as I'll show in a little bit, if I tell you that the Atkinson index for PM 2.5 in Massachusetts is 0.2, that doesn't tell you a whole lot. It's a number, and it's very hard to do much with that number unless you know that a policy option is going to move that up to 0.22 or down to 0.18, and then ideally you have a range of policy options and see which one, how each of them operates and how each of them moves inequality. So I'm going to show a couple of very brief examples before wrapping up. The first is from analysis that we did of air pollution in Massachusetts. This is from 1 by 1 kilometer resolution model that's been utilized in a number of epidemiologic analyses in and around Massachusetts. And so we looked over time at exposure patterns stratified by race, ethnicity, which is what I'm showing here, as well as income and education. What this plot shows is that you see racial ethnic differences and therefore potential inequities that hold up over time, where you see, for example, Hispanic populations have higher PM 2.5 than other racial ethnic groups. And you can see that the rank ordering is preserved over time, although even as air pollution levels have diminished in Massachusetts as elsewhere, the rank ordering is largely preserved. And as you can see in the plot, also because this could be confounded a bit by who lives in urban versus rural areas, we stratified by urban-rural status, and the differences persisted. And so we calculated Atkinson indices for these differences. A couple of things to point out here is, first, this is strictly looking at between group Atkinson index, so just the differences between racial ethnic groups or education or income. So we don't have the other dimensions. And another thing to note, if you look at the y-axis, is that these are very, very low numbers. I didn't mention when showing the Atkinson index that the numbers range from 0 to 1, where 0 is perfectly equal and 1 is perfectly unequal. These numbers are a whole lot closer to 0 than to 1. And this actually makes intuitive sense because these indicators first derive for income inequality, where income can span many orders of magnitude. And even going from, say, the 5th to 95th percentile of income, you're spanning multiple orders of magnitude, which for air pollution concentrations in a given state, you're nowhere close to. You're more like, a factor of 2, if that. So you have very low numbers, but that itself is not the point. The point is in part looking at trends over time and looking at how policy measures could change the distribution. So you can see in this case, inequality is greater looking at race, ethnicity than either education or income. And at least for NO2, there's a steady increase in inequality. For PM 2.5, it's a little spikier, perhaps an upward trend, but a little harder to discern. The second example is from an analysis looking at air pollution control strategies in Detroit. And this has a couple of interesting features. So here, the analysis was looking at two ways to control air pollution in Detroit: a standard way, which is the status quo, and an approach that actually targets controls in a way to maximize health benefits, the so-called risk-based. And what you can see at the top here is the multi-pollutant risk-based had health benefits roughly double the status quo. So by geographically targeting your control strategies, you're able to achieve greater health benefits. And the question was, what's the equity story there? What does this focus on efficiency, on getting better health risks, what does this actually mean for equity? And so here the Atkinson index was calculated, both looking at the total, which is the Atkinson column, and the between group versus within group. And an interesting thing is that the multi-pollutant risk base actually led to a greater reduction in the Atkinson and a greater decrease in the between group inequality. The status quo actually slightly increased the between group inequality. The numbers are obviously small in terms of both the values and the deltas, and this goes out 6 decimal places so you can see anything, but suffice it to say that this focus on maximizing health benefits actually was better for equity than the status quo. And this has actually been shown in a number of analyses and is actually somewhat intuitive, where if you're able to target vulnerable populations, especially living in densely populated areas, you might achieve both greater health benefits and reduce existing inequities. So just a couple more slides to wrap up. There's clearly some challenges in these approaches. I think one is that when trying to do these types of stratifications, again, based on race, ethnicity, or income or education, you're pretty well constrained to what exists in the census and other broad population data. So there's only so much you can do, and it's hard to capture all of the social determinants that Sam had laid out. If you want to also connect with epidemiologic evidence that includes effect modification, even more so, I think a counterpoint is that the groups that are of concern from an environmental justice perspective have been delineated, and most of those are captured in these census data. You obviously need fairly highly resolved air pollution estimates to do this well, otherwise you won't really have the exposure gradations. And at the end of the day, there's a real question of how readily decision makers can interpret these indicators, right? Again, telling a policymaker, you've reduced your Atkinson index from 0.2 to 0.19, you'll get a lot of quizzical looks. But again, it's about whether inequality is going up or down and whether your policies are really trying to move things in the right direction or not, and gives an opportunity certainly to do things that don't currently exist in regulatory analyses. So to conclude, I think the literature shows you can do this. You can meaningfully quantify inequality in air pollution exposure risk. This does have a strong equity interpretation given language in the executive order and others. There's a number of steps you can take to make these analyses as meaningful as possible, which I don't have to read for you here, but it really gets to having much more refined exposure and health outcome data, among others. And in terms of where this work can go from here, I think there has been a growing literature in the scientific community. I think that needs to increase. There's not been comparable uptake in regulatory analyses, and so I think there's importance of showing analytically how you can do this and how it applies in a variety of contexts, and then certainly pushing for regulatory analysts to take this on as a better way to explain distributions and address environmental justice language. And I also added here, if we're really trying to get a much more nuanced sense of equity and exposures, trending toward personal exposure versus ambient concentrations would be desirable. And I'll stop there. Thank you.
Thank you, John. The next topic that we're going to address is the role of socioeconomic status in studies of air pollution and health. And our speaker is Dr. Jane Clardy, Dr. Clardy is an associate professor at the Drexel University Dornsife School of Public Health, Department of Environmental and Occupational Health. As an interdisciplinary exposure scientist and epidemiologist, her research focuses on the combined health effects of chronic social stressors and air pollution exposures. Dr. Clardy completed her doctorate and postdoctoral training at the Harvard School of Public Health, was a senior research scientist at the New York City Department of Health and Mental Hygiene from 2008 to 2010, and was faculty at the University of Pittsburgh Graduate School of Public Health from 2010 to 2016. Dr. Clardy, I'll turn it over to you.
Wonderful. Thank you so much. And thank you all for making the time to listen in today. Thank you to the organizers at HEI and to my co-presenters. And it's a real honor to have this opportunity to speak today. So following on the two excellent presentations we've just heard, I'm going to shift the focus a little bit towards thinking about the nuts and bolts of accounting for socioeconomic status, or SES, in epidemiologic studies of air pollution and health effects. So I'll be very briefly speaking to why we should worry about SES and air pollution epi. I'll go pretty light there because we've heard a lot of good insight on this already. And talk a little bit about measuring SES and social processes in epi studies, why we have to pay so much attention to scale of measurement in SES, and to exposure misclassification in SES indicators. And then I'll talk a little bit about methods for incorporating SES into air pollution epi, and wrap up with some conclusions and thoughts for the path going forward. So as we've heard multiple times, SES refers to this massive gamut of exposures: healthcare, income, smoking, diet, everything you can think of, really. And these exposures are all aggregating and interacting over the life course and may even be multi-generational in their effects. So it's almost like everything else in an individual's life, aside from air pollution, when we're thinking about this in terms of air pollution epidemiology. But unlike air pollution, and what makes SES so difficult to work with, is that it's truly a relational or a relative measure. So unlike air pollution, where NO2 is NO2 is NO2, regardless of the setting that we're measuring it in, SES is really about an individual's relative standing within their society. And it is something that is very much based in perception, and it also really can vary with individual agencies, such as gaining education, and it shifts over time with societal changes, things like changing gender norms or the changing status of LGBTQ populations. Sam shared this excellent graph previously, and it's from a seminal study that was part of the Whitehall studies that came out in the early 80s in Britain. And it really it bears our attention to go back to this for just 1 second and really absorb what these studies communicated for the first time to us. It's that, first of all, these studies were done in a cohort of 18,000 British civil servants. These are white-collar employees with steady jobs who live in solid middle-class neighborhoods with good quality access to healthcare and food and all of those tangible things that we might worry about. And yet, straight across the job gradient, there was a very, very distinct dose-response effect in this case, likelihood of coronary heart disease. And then, so the gradient goes all the way across the social spectrum. It's not just about poor health in poor people. And the second thing that was critical in these studies is that the vast majority of this variation was not explained by the common risk factors we might think of, things like cholesterol, smoking, blood pressure, et cetera. Really, the vast majority of this gradient, this variation in health across the social spectrum, is something unexplained that this enormous body of literature in social epi since then has still been trying to detail what on earth is this? What is this thing that is just about status itself that we have so much trouble measuring, but seems to explain so much about health? So myself, Mark Cullen, and others looked at this same approach in the Alcoa aluminum manufacturers data. This is looking at about 50,000 aluminum manufacturing employees across the US. And we found that regardless of health outcome, this same dose response curve held up across job grades. So there's something very persistent about SES and health that we can't quite account for. So when we actually get into the nuts and bolts of applying concepts of SES in our epi studies, there are a lot of different measures that many of you have probably used or seen in other papers, indicators of income or poverty, wealth, education, etc. But it's important to recognize that none of these are perfect. None of these capture the whole gamut of that concept that is SES. And there is misclassification unique to each measure. Part of that means that we have to be very thoughtful about whether the measure we choose is appropriate to the cohort that we're studying. So for example, income is going to misclassify retirees or students, and likewise, education might misclassify young people who aren't done with their education yet. And there certainly have been generational trends in recent decades changing the value of, for example, a bachelor's degree. We also need to be thoughtful when we're trying to measure social factors or SES in being sure that the measure we're using is appropriate to the hypothesized pathway to health. And I think a lot about psychosocial pathways, and I'm very interested in those and how they interact with social or physical pathways for air pollution. So in the case of noise, an idea that's very much of interest is how much of the effect of noise is based on the physical impacts on the tympanum or through whole body vibration, and how much is about the psychosocial, the stress-related effects of noise. And those are two very different things. If I'm trying to understand noise as a physical exposure, I need to get a whole bunch of monitors and go out and monitor it and model it in terms of A-weighted decibels. If I'm trying to understand noise as a stressor, then I need to understand something about perception or disruption. So then I need to start thinking about survey instruments and going out and asking a lot of people, how frequently are you disrupted by noise? How bothersome do you find this noise? Do you find you can't concentrate because of noise? And those valuations, those appraisals are going to vary based on the quality of the noise and also on the characteristics of the population that you're working with. So there's this incredibly important role of scale when we're measuring SES or social variables. And this has been mentioned previously, but again, it bears, it merits a little bit additional attention to think about why things are fundamentally different when we measure them at the community versus the individual level, and why it's important to not use one as a proxy for the other if we can avoid it in our epi studies. So when we're thinking about community level measures, what they're really capturing is something about a community level process, something that is common to the whole community. A school district is a great example. You either live inside of that school district or you live outside of it. Or community resources, maybe a library. You have to live within that community in order to have a library card, for example. So these and other measures of crime and culture, these are things about the context of the place. And there are many, many other examples. But in social epi terms, this is really something that is a characteristic of the community itself, regardless of who lives there. And this is very different from the individual level characteristics that we're often hoping to capture in our epi studies and don't quite have the data for. These would be things like individual income or job strain, particular to that individual's occupation. These are referred to as composition in social epi. They are the characteristics of the individual who live in that place. And that's different from the characteristics of the place itself. There are absolutely interactions between these, cross-level interactions, but those are something that sort of specifically needs to be modeled in your study and explored intentionally. There are, just like at the individual level, a huge number of community level SES metrics and stressors we could be considering. This is a table from one of my studies where we looked at, I think this is about 27 different indicators of community SES and stressor exposures, and we've since extended this table. But we consider things like crime and violence indicators, physical and built environment indicators, noise disruption, child-specific stressors, things like percent of schools exceeding capacity. And over on the right, what I'm showing you is a map of just some of these indicators. And what you'll see is that, first of all, they vary tremendously across New York City in this case. And the patterns for many of them are similar. Some are reverse coded in the sense that higher is better rather than lower. So the maps are opposite in some cases. But there is a similarity to the maps, but there are also differences as well. And the reason why I point that out is that we kind of need those contrast communities, those communities that are high in income, but also high in crime, or low in one stressor, high in another, or high in pollution, but low in poverty. And what's wonderful about New York City is I have all of those crazy combinations to help us look at interactions. But we need that contrast in order to be able to tear apart these things that are often profoundly correlated and spatially confounded among themselves. So it's very hard to tear apart what their individual effects may be. So there are additional reasons to worry about scale when we're thinking about SES and measures of air pollution EPI. And first is that we very often use, almost by accident or not thinking about it clearly, very different scales of resolution in our pollution metrics versus our SES or social metrics. And many of us on the call, myself included, have spent an inordinate amount of time trying to build the finest scale, most accurate air pollution exposure models we possibly can. But then when we get to our EPI studies, we may make the accident of tossing in, along with our spatiotemporal air pollution indicator, an annual average census tract SES metric. So we kind of have to pay attention to that gross difference in resolution that we're sort of bringing into our studies when we have a very fine scale day in residence specific pollution metric and using something at an aggregate level that might be annual average to account for our social exposures. And think carefully about what patterns of misclassification then we're bringing into our studies that may be bearing out in ways that are hard to predict on our main effect of interest or main effect estimate of interest. Another difference here is that there may be true different underlying patterns in the actual true exposures that we want to capture. This is referred to as the uncertain geographic context problem in geography. So for example, we may know that pollution decays very rapidly within, say, 50 to 200 or more meters of a roadway. There's a very well-known kind of gradient in air pollution going alongside roadways. But social variables may vary at a very different spatial scale. They may vary at the level of school district or may vary truly at the level of community. So we sort of want to think about meaningful spatial aggregations at the same time as we also want to think about capturing both our social and physical environmental variables with equally resolved, equal quality information. So I'll speak a little bit to the different ways in which we incorporate SES into air pollution EPI, addressing both confounding and effect modification. And I'd also like to propose the idea of thinking about air pollution as potentially one mediator of SES effects on health and what that might offer us. So on the issue of confounding, this is conceptually pretty straightforward. Like we've come to accept in our science today that pollution exposures are often clustered in lower SES communities. And on average, lower SES communities tend to experience higher, at least primary air pollution exposures, though there are definitely some differences in that. We also know that some air pollution sources, such as traffic, are inherently confounded by a chronic stressor or SES exposures, things like traffic-related noise. There's obviously an inherent confounding there, and without sort of accounting cleanly for one, it's hard to know how much of the effect is really being carried through the other. But there are nonlinear joint distributions that can kind of complicate this adjustment or complicate our interpretability. Again, New York City is a great example of this. I'm showing here the joint distribution between a socioeconomic deprivation index and nitrogen dioxide exposures. In New York, we have the highest and most variable NO2 and the lowest deprivation, that is the wealthiest communities. That again offers us that nice contrast to work with, but clearly complicates sort of a straight confounding adjustment. We're also very concerned about effect modification by SEP in air pollution studies for many of the reasons that have previously been discussed. And there are increasingly more and more studies that show us stronger health effects of air pollution among lower SES populations. In my HEI report that is currently winding its way through the very thoughtful and extensive HEI review processes, we observed stronger associations between primary pollutants and risk of CVD in communities of higher stressor exposures, looking at quite a long list of socioeconomic and stressor exposures. And one of the real themes that we want to point out here, why this is so important, is that the more we can elucidate susceptibility and understand which populations may be most susceptible to air pollution effects, the more clearly we can identify opportunities to cost effectively pollution interventions and really optimize benefits in total. And then I mentioned that I wanted to float this hypothesis that maybe one way we might want to think about this is not so much how do we best account for SES, measure SES and put it into our air pollution studies. Maybe the other way we need to think about this is pollution might be one of the many different things that varies by SES And pollution is one of those ways that SES gets under the skin and ultimately impacts health. So maybe what we should start thinking about are mediation analyses or decomposition analyses, where we're really thinking about pollution being one of many, many things on the pathway from SES to health across the spectrum of diseases. What I'm showing you here are mutually adjusted negative binomial models. These are just ecologic models on the same scale. They're census tract annual averages for both pollutants and social stressors, each combination mutually adjusted. And when we look at them in this way, consistently, we saw that the indicators for SES or the stressors consistently had a much larger effect estimate than did pollution. That may not be terribly surprising because there's, for most of these variables, more variability in the social indicators than in pollution across New York City, although there's certainly plenty of variation in both. But really, when we step all the way back and sort of appreciate the fact that SES is trying to account for absolutely everything else in this person's life from the day they were born forward and even before for epigenetic effects, and we're trying to compare that against one single air pollution effect estimate, which just accounts for residential outdoor air pollution, maybe it makes sense that the pollution effects should look so much smaller. And maybe if we changed our modeling approach to think about whether or not pollution could play one important part along the pathway from SES to health, which interacts with a lot of other pieces on that pathway, a lot of other SES-related exposures, maybe then we would start to see a very interesting story emerge. So that is, of course, a future analysis to come, but a hypothesis or an approach I'd like to kind of put out there. So to wrap up, as we've heard many times now, SES is complicated. It's really complicated. It's a relational construct among individuals. It varies across space, time, culture, both at the individual and the community level. SES can play many roles in confounding or modifying air pollution effects on health, or potentially there's an important mediation we need to think seriously about. And pollution may be one way that SES gets into the body, which could very much change our modeling framework. Moving forward, I would urge thoughtful attention to the measurement of SES, making sure that the SES indicator selected is appropriate to the population under study, that is, captures the relevant variability in the population under study, and is specific to the hypothesized pathway. So again, if we're trying to hypothesize that something might be operating through psychosocial pathways, then how do we validate that it really is stressful? So we need to get to those perception measures somehow. I'd also like to call attention to those important issues of scale and the differences in not differential misclassification, but the different misclassification that we see in air pollution and SES when we tend to kind of rely on census tract or other readily available SES measures without kind of diving into their own patterning. Moving forward, I think there's a lot of work still to be done in elucidating the components or the stressors within SES that make up or explain the effect of SES on health, and may play very, very different, very much varying roles in confounding or modifying air pollution health effects. I think there's a lot of work to be done in multiple modifier models, because to the extent that we're thinking about effect modification and to the extent at which stressors and SES components are spatially correlated, then we really have multiple stressors acting simultaneously on modifying any air pollution effect. So for example, in my lab right now, we're trying to look at models that simultaneously account for both crime and poverty as separate effect modifiers of the pollution effects on CVD or on asthma. So, but really there's great coherent in the literature on the best way to account for multiple modifiers simultaneously. And then I think we have a lot of work to do in thinking about mediated modifier models to help us identify which specific components or stressors may be explaining modification by SES. So to the extent that SES is a modifier, observed to be a modifier of air pollution health effects, which of the many components of SES mediate or explain that modification? And that will help us to quantify that portion of the very, very large SES effects on health, which might actually be attributable to pollution. So with that, I'm going to wrap up and say thank you very much to HEI, both for their support in the study results that I shared today and for organizing this webinar today in lieu of the annual meeting, and to all of the folks who have worked on all of these studies. And thank you all so much.
Thank you so much, Jane. As always, a great talk, and so much to think about there. And hopefully we can pick that up in our question and answer session that will follow our last speaker. It's now my pleasure to introduce Dr. Veronica Eady, who's the Assistant Executive Officer at the California Air Resources Board, where she oversees environmental justice activities. She's the former chair of the US EPA's National Environmental Justice Advisory Council and was the principal author of the Massachusetts Environmental Justice Policy. She's held many important positions in non-governmental and other governmental organizations, and she holds a doctorate in law from the University of California, Hastings College. Dr. Eady, it's a great pleasure to have you here, and she's going to share her thoughts on Assembly Bill 617 and the quest for democracy in environmental decision-making.
Great, thank you, Dr. Jared. Let me just try and share my screen. Can you all see this? Yeah? Okay, good. I want to kind of frame my presentation in terms of taking some of what you've heard from the presentations that preceded me and kind of applying some of that into law and policy in California. I work for the California Air Resources Board. Some of you may know us, some not. We're a statewide air quality regulatory agency in California. We regulate directly greenhouse gases, mobile sources, consumer products, and a few other things. And then across the state of California, there are 35 local and regional air districts, and they regulate mobile sources. So AB 617, I will go into the nuts and bolts and frame it for you a little bit, but it is a law that we implement together in partnership with the air districts and also in partnership with local communities across the state. The story of AB 617 begins with California's Global Warming Solutions Act, known more readily as AB 32 or Assembly Bill 32. AB 32 required, well, first of all, it was signed by our former Governor Arnold Schwarzenegger. It was one of his key initiatives and accomplishments under his gubernatorial reign. It put in place a number of targets for greenhouse gas emission reductions, very similar to other programs in other states and other parts of the world. It frames a suite of programs. The most famous is the cap and trade program, both famous and controversial, at least in an environmental justice context, and I'll go into that a little bit more. But it also included or paved the way to a number of other programs that are also part of that suite, including the low carbon fuel standard, our RPS, mobile source strategy, et cetera, and including some of our car and truck emission standards. So one of the things that people in the environmental justice community here in California are concerned about is creating a market for pollution trading. When I came to California, I did a lot of reading about what environmental justice groups were concerned about in California, and the cap and trade program rose to the top. Part of the problem that people see with the cap and trade program is that it allows for the auctioning of allowances, which, as you may know, are basically permits to emit greenhouse gases. There has been some research both within state government California, as well as researchers, for example, at UC Berkeley, USC, Occidental College, who have done a lot of research around the relationship between greenhouse gases and other pollutants, harmful co-pollutants. So the theory here is that if a capped facility, a facility that's regulated under the cap and trade program, is able to buy allowances to emit greenhouse gases, in theory, they may be also able to emit more greenhouse gases than they otherwise would by purchasing allowance, and thereby the co-pollutants also increase in the communities that host these facilities. So CARB's sister agency, the Office of Environmental Health Hazard Assessment, released a study in February 2017 looking at the relationship between greenhouse gases and more harmful air pollutants, PM 2.5, for example, and toxic air pollution. It looked in that first report at refineries and cement plants. And so you see here on the right, the image is of maps of disadvantaged communities in California and where these sources are located. I will say that as a bit of background, disadvantaged communities is a legal term that was defined in SB 535 and actually led to our sister agency, OEHA, creating Cal EnviroScreen, which is our pollution mapping tool that looks at 20 indicators, 10 of them being socioeconomic and 10 of them being environmental. So what does that look like? Well, we have a slide here of some of the communities around capped facilities and other sources of pollution. The house, the red house that you see at the top, is literally separated from the refinery complex behind it by a low chain link fence. And then to the left, I want to point out the image of the people standing around this house and the image below us. If you look at the top of the crest where people are sort of standing around that house, you see tank farms. This is also, I should say, this is a public housing development. It's a community called Bayo Vista, which is in Rodeo, California, in the San Francisco Bay Area. So last year, that tank farm at the top of the hill exploded, and you see the photo behind it of the emissions from that tank farm. So this is somebody's neighborhood. And it's incumbent upon us as state government, as we implement our cap and trade program, to focus on reducing emissions in the communities that neighbor these capped sources. So in 2017, the legislature passed AB 398, which was the extension of cap and trade to 2030. And with it came AB 617 as a companion bill that is aimed at reducing exposure to other emissions. And you can see from this slide here, that looks at diesel PM, although emissions overall of diesel PM have reduced significantly over the years. The red line represents disadvantaged communities, communities of color, low-income communities. And so they have not seen the reduction in air pollutants that have been seen statewide. Clearly there's a job to be done here, and AB 617 was put in place to help take care of that. So I will talk at a very high level about some of the elements of AB 617, and then we'll get into the democracy of it. So AB 617, as I said, is a joint implementation program between CARB and the local air districts, and also calling for, as I say, partnership with local communities. The components include monitoring. So in communities where there is not enough air quality data on the local scale, air districts have instituted local air quality monitoring programs. Ultimately, that data and the other data taken together is used as the basis for an emissions reduction plan. There came with the AB 617 funding for incentive programs and community assistance grants, which are intended for local community-based organizations to be able to participate in the program. I'll talk about that a little bit more. And then it also includes us building a data visualization tool called AQView, and I'll talk about that in a minute. So in the first year of the program, and I should say that the bill was passed in the summer of 2017, so it's almost 3 years old. CARB's primary role was, first of all, to identify the communities that would be the central focus of AB 617. In the first year, we identified 10 communities, looking at things like Cal-Enviro screen, modeling, health indicators, but we really sought to have a variety of communities from across the state. So you can see from the map on the right that we included Richmond, California, which is a refinery community. West Oakland has a port in it. Shafter and Fresno, to a certain degree, are agricultural communities, as is Imperial, that you see way down on the Mexican border. So we really sought to have a variety of communities. And then we had, just this past December, the board, CARB board approved 3 additional communities of Stockton, Southeast LA, and the Eastern Coachella Valley. So I included this slide building on current efforts because AB 617 in many ways was, the bill itself was modeled after a community air monitoring network in the California-Mexico border region called Imperial County. This is an air quality monitoring network. It measures PM10, PM2.5. It is managed and owned by a local nonprofit organization called Comité Cívico del Valle, along with other partners who helped Comité or CCV obtain a $2 million NIEH grant. That was the seed money for this network. CCV worked also with a public health agency organization in California called Tracking California, as well as academics at the University of Washington. The initial network was 40 low-cost sensors. They, as part of their model, created a community steering committee, and that steering committee helped them identify where pollution hotspots possibly were and where new monitors should be put up. Some of the members of the steering committee actually hosted monitors, and so you see that here, and this image is a more recent image, so there are more than 40 monitors now. But originally we did have just one monitor in Mexicali that was hosted by a member of the steering committee. Now we do have more in Mexico, and actually that has been really helpful, not just for monitoring the local air quality, but some of that data feeds into things like Cal-Enviro screen, and also assists local government in Mexico address air quality issues there. A key part of this IVA network was having publicly accessible data. So the image that you see is a screenshot taken from their website where they display air quality data. They also had a number of schools where they hosted monitors, and there's a curriculum around the school flag program where kids from the schools monitor the air quality throughout the day, and then they raise a flag based on the air quality of red, yellow, or green. And that way, school teachers as well as families can access the data and make decisions about whether or not to allow children to play outside and other things. The Imperial Valley region is a desert region, so PM is a large part of what they're facing. Not only is there fugitive dust from the sand, But there are also many unpaved roads, there's agricultural burning, a number of PM sources there. Our emissions reporting tool that is part of AB 617 is called, as I said, AQView. It's a statewide network. We're ready to launch it, but we're collecting not only data from the 35 air pollution control agencies that regulate stationary sources, but we're also using community generated data. And we are also putting together community emissions inventory based on the 13 communities where we're currently working on air monitoring and emission reduction plans. So in terms of success and tracking success, I should mention that one of the things that we did under AB 617 is that we put together an advisory body called the AB 617 Consultation Group. And we're very fortunate to have Dr. Jarrett as part of that group who advised us through the implementation of AB 617. One of the big issues of local residents living in the communities where we're focused, as well as many of the doctors and public health experts who serve on our advisory committee, is there's a real concern about public health goals and thinking about how we tie AB 617 to public health. How do we embed public health metrics so that as we are implementing the program and reducing emissions, we're also tracking to make sure that those air quality measures are leading to improved health within the communities where we're working. We're in the process of developing those metrics. I have to say that while at CARB we do consider ourselves a public health agency, there are some air districts who actually have seen the challenges of using public health as a metric. So we're working with our consultation group to work through some of those things, as well as setting clear metrics. The public process continues and community engagement continues through the implementation phase. And at this point, we do have 7 of the 13 communities that have community emission reduction plans that are going into the implementation phase right now. So we continue the public process, the steering committees that are associated with each of those communities, and that again is based on the IVEN network model, continue to meet. Funding is a huge challenge, and particularly in the current budget crisis that California and many other states and air districts are facing. Our funding for this program is actually from cap and trade proceeds. We, as an agency, CARB certainly supported the funding through the cap and trade program, but also the point of the cap and trade program is to, or a key part of it is to ratchet down that cap annually. So as we ratchet down the cap, we also reduce the amount of allowances that are auctioned off, and that reduces the pot. But in this current funding crisis, we're seeing other needs for cap and trade funding to keep California going. The original budget included implementation funds, much of which came out of the cap and trade pot. And right now we're in the process of working with the governor's office, of course, and the legislature, but also with the districts to think about how the program continues in the current budget crisis. And it will certainly continue. So here I wanted to raise a couple of things. One is, so we've seen $695 million appropriated in incentive funding targeted in these 13 communities. Some of the examples are zero emission school buses, ZEV infrastructure, stationary sources this year, and looking specifically at hexavalent chromium. But we've also funded things like zero emission or lower emission agricultural equipment. We, in some of the rural areas, have funded paving roads and paving trailer parks. So it's been, in addition, indoor air filtration, particularly in schools. This year, though, the budget bill that passed appropriated $200 million for incentive funding, also created a new category, which is the text that you see here, community identified projects. So these projects are projects that have gone to the local steering committees in the 8617 communities, and where those members of the multi-stakeholder steering committees have identified projects that they think should be prioritized for incentive funding. And then the Community Assistance Grant is a funding program that goes to support community groups who are engaged in the 8617 process. $15 million has been generated thus far. Much of that money was to erect community air monitoring networks similar to the IVAN network. We've certainly also funded the IVAN network to expand, not just in the Imperial Valley region and the Salton Sea region, but there also are now monitors in San Diego, as well as in the San Joaquin Valley, the southern San Joaquin Valley. And what you see right there, the image is one of our environmental justice partners, Jesse Marquez, who is in the LA Wilmington region. So you can see a refinery behind him there. And he is, and his group, putting up a local air quality monitoring network. So next steps. First of all, we've learned a lot of lessons throughout this process. And as we entered the process, we saw a need to work with UC Davis and other academics to help us evaluate first the community engagement and how effective that was, but we're also thinking now about the implementation phase and if there's a role there for that program evaluation work to continue. Some of the issues that our UC Davis academics, researcher, in particular Jonathan London at UC Davis, identified was that there was a range of governance issues, and when you think about democracy, think about how these steering committees are governing the process. So there have been some real challenges around sharing power, both between CARB and the local community and the air districts of the local community. You can imagine that for agencies that have been around for more than 50 years, like CARB and the local air districts, sharing power and doing things differently is a real challenge for us. So we're still working through that. Stipends, some air districts provided stipends for people to be able to participate, some didn't. That certainly came out of the UC Davis report as a recommendation that across the board we are helping local residents to participate in the process by supporting them with stipends. I mentioned the funding process and the Greenhouse Gas Reduction Fund, which is our cap and trade proceeds. In the current budget crisis, a number of projects, including the Community Air Grants project, are a lower priority for the GGRF. So we are thinking about how we can continue a grant program, and districts are also thinking about fees and whether that's something that they need to do to be able to continue the program. I mentioned the public health indicators. There are some people, particularly at air districts, who see public health metrics as mission creep. So we are working with our advisory body to think through how we can effectively use public health measures as metrics for success. And finally, looking towards the future, ongoing work, of course. The second bullet, though, around transferability really does play into the democracy issue in my mind. We went about having a host of communities from across the country or across the state that looked different. Refinery communities, port communities, agriculture communities, desert communities, as I mentioned. And part of the idea around that was to develop strategies that can easily be implemented in other parts of the state in similar communities. So right now, with the reduction in funding that is on the horizon, I am helping my agency think through the transferability issue and whether or not, if there are funding under the community air grants for community-based organizations that can support community-based nonprofits to take some of those strategies and implement them on their own. So we're working through that, and hopefully in the coming year we will have some sort of a pilot to see whether that can be done more broadly, completely community-led. We are supporting community capacity building. We do annual reviews, and of course, we're looking at new communities coming up in the future. And although in the budget scenario that we're in, there will certainly be fewer communities that we are working in and that we bring to the board, hopefully there will be at least a small handful of new communities that will come online. So I'll close there, and I thank you for your attention.
Thank you very much, Dr. Eady, for that comprehensive and very thoughtful presentation of California's leading efforts, I think, to address inequalities in air pollution exposure and their potential health risks. I want to remind everyone that we have a question and answer box that you can submit questions for our panel. We're now going to turn to question and answer and panel thoughts and discussion. So hopefully we'll get lots of good questions from the audience. And I think Dr. Milford has one to start the questioning. So I'll turn it over to her now.
So just want to echo the thanks to all of our speakers. It's been great to have the array of presentations covered. And we're all going to start our videos now, and I'll ask all of the speakers to just go ahead and unmute, and we'll try to make this discussion as interactive amongst the panel as possible. So I am going to lead off with a question about COVID-19. A couple of the speakers brought up the potential for interactions between COVID-19 and air pollution in terms of the inequalities that we've seen. And so this question is for all of the panelists. What do we need to know or learn about connections between COVID-19 and air pollution in order to better protect people in disadvantaged and vulnerable communities with disproportionate air pollution exposure that may or may not factor in? So anybody want to take a stab at that question? I know some of you are working on this.
I can jump in and go from there. I'm hearing a little echo. I mean, there's a lot of dimensions to that, and it's hard to know where to begin. I think, one of the things that we've tried to emphasize is, first, historic air pollution, long-term air pollution exposure would likely increase the prevalence of conditions in these communities that might make one vulnerable to the effects of COVID. So that's one dimension, is if you have more COPD, more heart disease in a given community because of the historic air pollution burden, which has been disproportionately distributed, you may have more vulnerable populations. So that's one slice on things. In terms of sort of contemporaneous air pollution exposure, right? That's a really complicated question, since air pollution is going down some places, not to the same extent every place. For things like PM and ozone, it's not clear how much it's going down in many communities given secondary reactions. So there's an exposure story there that's fairly complicated. The other thing that we've been thinking a lot about is the fairly obvious point that our time activity patterns have shifted quite a bit in the last couple of months. And so personal exposures are principally a function of what you're exposed to inside of your home. And so the ambient condition has changed, but also the indoor condition has changed. And that has the potential to further exacerbate inequities and environmental justice issues. You know, we and others have shown in the past that lower income populations who live in smaller homes and may have more prevalent use of combustion in their home environments may have elevated personal exposures. So you may be having, even if ambient conditions are looking okay, you may have increased gaps in the exposures and perhaps even increases in the exposures to some key pollutants among vulnerable populations. So, you know, it's messy, and I think we need to look at all kind of long-term, short-term personal exposure, ambient.
Thank you. Other panelists want to weigh in on that question?
I'd like to chime in a bit, if I may. I think it's a fascinating question and potentially a really interesting interaction. And I think the air pollution story that's going on right now is extremely engaging. It's very, very, very early, though, to really know for sure how this is all going to play out and how these two very different types of exposures may interact. Certainly, COVID being a respiratory illness and air pollution directly impacting the lungs, there's no question the two very different physical exposures impacting the lungs simultaneously can't really be a good thing. But the other thing I think is really happening right now that I think is very important is potentially a strange silver lining in all of this, is that we are seeing a very tangible example of health inequities that have been there for a very, very long time. And what we're seeing is the demonstration that the same susceptibility factors that may make people susceptible to pollution are also making them susceptible to COVID. And we sort of have the world's attention to understand that right now, and that's a very important opportunity.
Others on that question?
Yeah, so I think that another question is to think about how does long-term exposure to air pollution influence recovery from COVID and disease severity. So are we seeing more people going into ICU or advanced oxygen therapy and ventilators when they're coming from areas of high pollution? Certainly in California, when we've been looking at the Kaiser Permanente data from a 4.5 million patient database, we see very strong racial gradients, so that people who are Latino are 1.5 times more likely to be admitted to ICU. African Americans about 1.4 times more likely compared to whites. So there's this component of severity that I think needs to be investigated. And then another question is long-term recovery for those that are fortunate enough to get out of ICU. What are the long-term consequences, and are those influenced by air pollution exposure? And then I think another important component here is that the people who are in disadvantaged communities are often disproportionately employed in service sector industries like grocery stores and other, hair salons, places where there's going to be a lot of close contact and a lot of virus shedding going on. So their exposure to the virus is elevated. And I think that's a good example where they're getting, elevated exposure to both air pollution, which perhaps predisposes them, and then also to the virus itself. So their risk is going up as a result of that dual exposure that relates to their social position and their occupation.
Thank you.
I think that also applies potentially to healthcare workers. Certainly in Montreal, where I live, we've seen some of that happening. And so I think there's an interesting intersection, not just with different occupational potential routes of exposure. I think the other thing that's interesting is the way that also intersects with, of course, policies and the extent to which policies have been implemented to try and impose social distancing or to reduce the amount of social distancing, and how that may intersect with longstanding, other, government orientations that have allowed for systemic discrimination in environmental exposures. And so it speaks a little bit actually to one of the points that Jane, I think, alluded to is there's a tendency for some of these things to sort of occur together. And I think we've seen some of that already in the early results, just looking at racial differences and deaths from COVID across different states.
We've certainly seen overlap between our AB 617 communities, in particular in the LA basin, and COVID-19. I mean, just looking looking at it on a map, there's very clear overlap between where we're working and the hotspot in COVID hotspot in California, which is Los Angeles County. We do have a research division at CARB, and our research division is right now thinking about how they might study that or replicate the Harvard study focused in California.
Thank you. Next, I want to turn to some of the questions that we've received from the audience. And Veronica, this first one is for you. You answered it on the chat, but I'd like you to maybe address it for everyone. And that was the question about what are some of the health metrics that you are considering as you try to make that link between emissions reductions and public health?
So right now, what I mentioned in the chat is that asthma and respiratory disease is something that's pretty obvious, and a number of the nonprofits that we work with in these AB 617 communities are also have asthma programs and do asthma interventions. So those are kind of the immediate things that that we're thinking about. You know, I mentioned our research division and some of the research that they're doing, which will overlap with AB 617 and be able to really help us evaluate what might be good health metrics, is in the Salton Sea region. I showed that slide that had Imperial County and all the monitors in it. The Salton Sea region is an area that has been of particular concern because the Salton Sea is receding as we put less, or as it receives less and less water. Salton Sea is an artificial body of water that was created by accident, and it's something that the community really values and is part of their identity, but because of our water management issues, it's receding. It's received a lot of agricultural runoff, and therefore there is a lot of toxic air contaminants in the playa blowing off the sea. And so our research division is right now getting ready to respond to some local residents who do have concern about asthma and respiratory disease and nosebleeds that children are experiencing. So that might be an area, while the Salton Sea region itself, the sea is not an AB 617 community. The south part of the sea is Imperial County, which is, and then the north is Eastern Coachella Valley, which is. So it's sort of sandwiched in there, but the research that they're preparing to do hopefully will also give us some more guidance on how we would develop public health indicators. But I did mention that Dr. Jarrett is on our AB 617 consultation group, and so I'd be interested in hearing his thoughts about it.
So in terms of the health indicators, you know, I think that as we move toward spending a lot more money on the emission reduction programs, there are many opportunities there to conduct natural experiment research. So that quasi-experimental design is going to have to use fairly sensitive indicators of health effects, whether it's something like A1C measures for diabetes, or the Propeller Health asthma rescue inhalers, which do a GPS mark on every point where there's a rescue inhale. Those types of very sensitive measures, I think if we can show that those are coming down as a direct result of the emissions reduction programs and do that in a well-designed study, that will certainly lead to demonstration that these projects are having tangible health benefits. I think the administrative data is a good start, but it's not that sensitive to these changes over time. The other option that we've used for some HEI funded studies on accountability is to get into the Medi-Cal data, which is basically the healthcare that's provided in California for people that are socially disadvantaged, and to look at people with pre-existing conditions. We do find that they respond to relatively short-term changes, but it's a complicated access to get that database, and it has to be maintained in a very secure location. But I think moving forward, those more sensitive health indicators are going to be needed to really demonstrate the benefits of these programs.
So we've had a couple of questions that I'm going to try to pack together. I hope it's not inappropriate to do that, relating to the challenge of multicollinearity or spatial correlation amongst the factors that might be considered social determinants of health interacting with air pollution. So I wondered if a couple of our panelists might want to address the question of available methods to get around that challenge. Jane, I thought you might want to tackle that one, and Sam might as well. So,
sure. Is this perhaps in relation to the question that was raised for Sam regarding data reduction? I guess one thought that I had is that there are indeed methods for combining multiple social metrics into a single index for use in epidemiologic studies where you may have lower statistical power than you wish you had. There are good examples of doing this and there are bad examples of doing this. The way that would be less preferred, of course, is to take a whole bunch of metrics and kind of add them up together. Because each one is going to have its own patterns of error and they are highly collinear and they do have unique spatial patterns unto themselves, so you may wind up double counting some things, undercounting some things. Your weights would be kind of, by assuming uniform weighting, it doesn't really make sense that 1 unit of violence is equivalent to 1 unit of poverty when we sort of create a merged index without some kind of weighting system entailed. We've had a little bit more luck exploring things like spatially stratified PCAs and other methods for kind of determining, when we have a very long list of social indicators, which ones generally tend to track together and which ones don't. So kind of leveraging the spatial correlation where we can to try to create a composite that's based on really just observed, based on observed patterning in our data. The important thing that we've done, though, by virtue of spatially stratifying these, I think, is that it does give us some opportunity to look at sub-areas and make sure that we're not missing important indicators that are really critical in one sub-area, but would be washed out across the whole. So in general, I mean, the suggestion would be, know your data set very well, understand the patterning and the spatial correlation among the variables that you're working with, and then merge them in a way that is, capturing the layers of variability that you need to make sure that you're capturing variance both locally and then globally across the data set.
Yeah, I would just add, I mean, Jane answered that very well. I would, the only other thing I would suggest is to think, I mean, there is a huge literature on, methodological literature on this out there to explore, and I encourage you to explore it. I think the only other thing I would add is that it gets a little bit to our question about thinking about fit for purpose. So, it depends a little bit on what you're trying to achieve with, let's say, building an index. Is the idea that, if the idea is that you really want to try and, let's say, use a community level socioeconomic index as a confounder in a study, in some respects that is a stronger case for trying to build a nice index and avoid this multicollinearity. On the other hand, if you're interested in sort of a community level socioeconomic measure as an exposure, I think that's a little bit more challenging, because if you then see that the exposure has some impact on outcomes, it's very difficult to know what parts of that exposure you would intervene on to change it, or how a 1 unit change in this index would actually change health outcomes if we thought about an intervention. So when you turn it into this sort of latent construct, it becomes a little bit murkier and a little bit harder to think about it in terms of interventions and manipulability.
Okay, one other question. This one comes from me, actually. Since we've got the gamut run here between academics doing research and policymakers trying to decide what to do about this, John, you brought up the challenge with the Atkinson Index of sort of communicating with policymakers about what that means. And I wondered if the panelists could just briefly address the question of what are best practices for communicating information about inequality with policymakers and with communities that are impacted themselves. So John, maybe you could take that, and Veronica, and then others as well.
No, it's a really good question. I mean, I think it comes back to that phrase of fit for purpose that, Sam and others were using before. For example, we've been doing some analyses of, COVID-related inequality in Massachusetts. We have not used Atkinson indices or anything resembling that. We've done simple graphical plots, color-coded, stratified by percent, racial ethnic minority, because that is the message that we wanted to convey, is a broad sense of pattern and of disparity, and that is the key message. So, again, as someone who's done this Atkinson index stuff for a while, I'd be the first to say, right, it is not the end-all be-all, and it is only useful in very specific contexts. If you're doing regulatory analyses and you're comparing 10 alternatives, and you want some systemic way of saying which ones seem to do a better job than others, it allows you to do that, so you're not making a mistake just by looking at what was the 95th percentile exposure or the median in each case. So I think, these inequality indicators have, I think, tremendous value to synthesize complicated data and allow you to move forward on an analytical front, but they're not the best mechanism to communicate. I think, a simple chart or graphic can be far more powerful in a lot of policy contexts.
Yeah, it's a very interesting question. CARB is kind of a unique agency because while we are regulators, we also have a very robust research division and research agenda, and we work very closely with university researchers. So there haven't been as many challenges in communicating or turning it into policy, because we are, we do function in the research realm. But some of the bigger challenges, I think, are how we're communicating with local residents, and how can local residents help us develop our research agenda, which then would be turned into policy. It's a constant challenge, although I will say that in my time at CARB, it's become abundantly clear that the local communities that we work with actually are very fluent on a number of the issues, especially the ones pertaining to asthma, respiratory disease, and the illnesses that are related to air quality.
Did you want more commentary on that, Dr. Milford, or do you want to go on to another question?
I think, Michael, we might let you have the last word if you want to respond to that question, and then we'll turn it back to Pallavi to close. So.
Yeah, I guess several years ago, I did a lot of work on cumulative effects indicators, and it was a Gini type model. Similar, it's not that different than the Atkinson index. And I found that was completely intractable for community groups. And, every time we would try to show it, it would generate more confusion. So we moved to doing more mapping of the cumulative risks, so people were really able to grasp that. And then I think some of the experiences we had early on, and Dr. Rachel Morel-Frosch from UC Berkeley and Manuel Pastor were aware of our work. That spurred them to go and try to develop the Callan virus screen, which I think has now become a very powerful tool for communities to understand the cumulative risks they face. It's maybe not as scientifically satisfying as an Atkinson index or one of these cumulative indices, but it is something that's tractable for them, and they understand that they're in an area that is facing multiple, both health challenges and exposure challenges.
Okay, thank you. Well, thank you to all of our panelists for the Q&A, and apologies to the folks who submitted questions that we didn't get to. We are at the end of our time. So just thanks to everyone for a great webinar, and I'm going to turn it back to Pallavi to close us out.
Thank you, Jana, and a big thank you to our chairs and speakers for a very fascinating session today. Clearly, there are a number of challenges that we still need to address, and we're hopeful that future and coming research in coming years will continue to address the issues that have been raised today. A big thank you also to all of you for joining us today and throughout this HEI webinar series. We really hope that you'll continue to engage with HEI in the future. Please do send us your ideas and feedback regarding future webinars and this entire webinar series. And with that, I will close today's session. Thank you very much and stay safe.